Consultant radiologist in King Saud University.
Thank you, Mr. Chairman. I'd like to thank the organizing committee to invite me about this talk. Talking today about vertebroplasty versus kyphoplasty. This is the question. The agenda of this debate will be disclosure of conflict of interest, a definition, palliative effect of the vertebral augmentation, some safety issue, complications of both, some recommendations, word about economics, and finally, my opinion. No conflict of interest is declared. The definition of vertebroplasty is the injection of polymethyl methacrylate through a transpedicular approach into the heart of the vertebral body. This is what it looks like on lateral radiograph or lateral fluoroscopic image. Kyphoplasty, as Dr. Munir showed us, is the same, but with the formation of a balloon and a cavity inside the vertebra. This is a case of a 45-year-old male who had osteoporotic and presented with acute back pain. He was shown on MRI. This is a stir sequence and a post-gadolinium image to have extensive edema in the vertebral body of L3 and compression and loss of height of the vertebral body itself. Following contrast administration, it showed extensive enhancement, which shows us the acuteness of the case. We performed a percutaneous vertebroplasty and injected approximately 3 cc's of polymethyl methacrylate. The patient pain score dropped from 10 out of 10 on the VAS score to 2 out of 10. Now, the main idea for vertebroplasty or vertebral augmentation is pain control. Vertebroplasty and kyphoplasty are equally effective. They have been both reported to have multiple complications, local cement leakage, such as in this case that we injected 2 vertebral bodies. Unfortunately, we had a minor leak in one of the anterior vertebral veins, which did not propagate any further. Pulmonary embolism has been reported, and in this case that was sent to us from an outside hospital in a patient who had acute chest pain 2 days following vertebroplasty, and this is a non-contrast CT scan. There's no contrast in the heart, but there is polymethyl methacrylate in the pulmonary veins. Patient, however, made it and survived. It is questionable whether the relative risk of developing an adjacent level vertebral fracture occurs, particularly in recent studies and particularly after the patients have been treated well after their first vertebral fractures. The majority of complications, fortunately, are clinically silent. So back to the question, does vertebroplasty really cause an incidental vertebral fracture? Well, the biomechanical data tells us that due to the altered biomechanical appearance, the vertebral body will be very strong while the others are very weak, and the patient continues to have osteoporosis. So numerous authors have published studies that include data on rates of incidence of fractures after vertebroplasty. However, new fractures after vertebroplasty may actually represent the natural history of osteoporosis rather than a complication of the procedure itself. So even in my opinion, the orthopods admit that there isn't much difference between vertebroplasty and kyphoplasty. Both are safe and similar. The safety issue is both procedures provide quicker pain relief, mobility recovery, and return to normal daily activity and restoration of normal lifestyle. The long-term benefits and safety in terms of risk and subsequent fractures have not been clearly demonstrated, and further prospective randomized trials are still needed. This is a study from the publication from the Belgium group, who reviewed all articles published between 1980 and 2008, reporting the outcomes after vertebroplasty and kyphoplasty for either osteoporotic fractures or tumor-related compression fracture. And their conclusion was, although there is evidence to suggest that physical disability, general health, and pain relief are better with vertebroplasty and kyphoplasty, high-quality randomized trials after 2-year follow-up are still needed, and the reported incidence of symptomatic procedure-related morbidity is very low. This is a study from Kieran Murphy from the Johns Hopkins group, who showed 6 major complications out of 531 patients, which is equal to 1.1% that were treated with kyphoplasty, were reported in a multicenter trial. This complication rate is quite similar to the vertebroplasty complication rate, which is 1.3%. See, comparing contrast 1.3 to 1.1, 1.3 for vertebroplasty and 1.1, which is clinically non-significant. So the recommendation is that from the group of China that studied approximately 848 patients, that vertebroplasty, considering its lower cost, it's probably a better option for you than kyphoplasty. Some issue about hospital cost economics, and particularly in these tough and tight days. Performing vertebroplasty versus its kyphoplasty reduces the hospital cost by approximately $5,000 in inpatient procedures, and by more than $4,000 for outpatient procedures. Just from personal communication, I can tell you that the vertebroplasty costs around 1,000 riyal, and the kyphoplasty around 10,000 riyal. So it's quite a big difference from a hospital economic point of view. So which is better? I think both are useful in management of vertebral pain. Vertebroplasty is better indicated for vertebral fractures due to osteoporosis, hemangioma, or metastasis. On the other hand, the group from Napoli found that kyphoplasty is suggested in acute traumatic fractures of type A1 and A3. This is an important paper that came out recently, and it was published both in radiology literature and neurospinal literature. It is a position statement on percutaneous vertebral augmentation, a consensus statement developed by the American Society of Interventional Therapeutic Neuroradiology, Society of Interventional Radiology, and the American Society of Neurosurgical Surgeons. It states that vertebral augmentation is safe, efficacious, and a durable procedure in appropriate patients. The procedure is offered only when traditional medical treatment has not provided pain relief. Multiple case series and retrospective and prospective non-randomized studies have shown that it is statistically significant improvement in pain. The results have been confirmed in a prospective study with the use of control group, and the benefits of vertebroplasty far outweigh its risk and the risk of conservative therapy. The success rate is consistently high. Finally, my opinion as a musculoskeletal interventional radiologist, which is evidence-based. Do I believe kyphoplasty is safer than vertebroplasty? No. I think both are similar. What are my indications for vertebral cement injection procedures? Palliative and palliative only. I really do not believe that there is any restoration in reality. I mean, restoration from 6 millimeter fracture to a 3 millimeter fracture is not really restoration. Do vertebral cement injections increase the risk of adjacent fracture? Is there a difference in this between vertebroplasty and kyphoplasty? No and no. The older literature suggests that there is a greater risk of adjacent level fracture after vertebroplasty. This has not been demonstrated in recent studies. My take on the New England Journal of Medicine: a couple of years ago, the New England Journal of Medicine came up with 2 studies that showed vertebroplasty was no better than the placebo, and it really ruined it for the vertebral augmentation for a couple of months. Some of the oncologists came over and told me, your work is over. When we look into it further, I think both studies had flaws. The conclusion is different from my own experience, where patients really have a very good outcome. The CALM study in the New England Journal of Medicine screened a large number of patients, but enrolled only less than 10% of these patients. Usually for a multicentral trial that requires 20 to 30% enrollment. The recruitment of the patients with very low pain scores of 2 and 3 on the VAS score, which is quite low, and which was most likely going to improve without any intervention. Most were chronic fractures, meaning more than 5 months, that were enrolled in these studies.
1 minute, please.
And the sham procedure was not really a sham procedure. It was actually injection of percutaneous lidocaine. And there was a trend in both studies that VP patients did a little bit better, and no clear correlation between the patient's pain location, severity of pain, imaging findings, and pain on physical examination. The CALM study did not even do an MRI and bone scan on each patient. To summarize this debate, I gave some definition, palliative effect of the procedure, the safety issues, complications, and my opinion, which at the end Do whatever you are comfortable with. If you're trained for vertebroplasty, go ahead and do vertebroplasty. If you're trained with kyphoplasty, go ahead and do with kyphoplasty. Working as a team between the clinician, radiologist, and the endocrinologist gives the absolute best results and best benefit for these patients who really have a terrible time with these fractures and would likely benefit with this picture. Thank you very much.